You're listening to This Week in Cardiology from theheart.org on Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for February 28th, 2020. This week, tension in social media, changes in CMS, bempedoic acid, and carotid interventions. First up, the K-index sounds scientific, doesn't it? Noted meta-researcher Dr. Shazab Khan from Stroger Hospital in Cook County, Chicago, whom I have co-authored with in the past, along with a number of other co-authors, have published a provocative paper in JACC Case Reports on the Kardashian Index. That's right. The Kardashian Index, or K-index, is a measure first proposed by scientist Neil Hall back in the journal Genome Biology. This was a measure of the discrepancy between a scientist's social media profile and publication record based on the direct comparison of the number of citations and Twitter followers. Hall's concern back in 2014 was that there is a danger that social media as a form of communication is gaining too high a value, and that we're losing sight of the key metrics of scientific value, such as the citation indices. Of course, that very notion assumes the citation index is a good metric. Nonetheless, Dr. Khan and colleagues had the idea to apply the K-index to cardiologists. First, they searched the top 100 cardiology hospitals and then randomly sampled 1,500 cardiologists from these hospitals. Of the 15 cardiologists, get this, only 238 were found on Twitter. So right there, they point out that despite the concerns over Twitter, that is a pretty low penetration. They calculated the K-index as basically the number of followers a physician has on Twitter divided by the number of followers a physician should have based on that physician's number of citations. A higher K-index suggests that a physician may be over-celebrated due to his or her active presence on social media. Physicians with a K-index of greater than 5 are considered to be, quote, Kardashians of the academic world. Now, the findings of the paper are pretty mundane. The majority of cardiologists have a very low K-index of between 0 and 2, and very few, only 25 of 238 cardiologists, had a K-index over 5, and thus could be called Kardashians. So assuming that this random sample was indeed representative, this paper found that most cardiologists are not on Twitter, and of those that are, few have imbalances between their Twitter following and their citations. But what wasn't mundane was the accompanying editorial from Dr. Robert Califf, who is a true giant in the field of cardiology. His accomplishments are too numerous to mention: trialist, teacher, incredible public speaker, former FDA chair, and I am sure one of the most cited cardiologists ever. What was provocative about his editorial was the tone. But before I tell you about that, recall that it was Dr. Califf who tweeted on September 27, 2008, around the time of the controversial COAP trial, quote, "And now we have a social media peanut gallery of experts, many of whom have never designed or conducted an outcome trial." In the JACC Case Reports journal, Califf writes, quote, "The K-index is an oblique way of addressing an issue that is bothersome to researchers who have paid the hard price of designing, conducting, analyzing, and publishing research." Again, Califf says, "Another person who may have only casual knowledge of what is involved in the research may then make a comment that attracts enormous attention." He goes on, "People with a high K-index may be those who thrive by commenting on the work of others rather than doing their own work." He then goes on in the next paragraph to cite Teddy Roosevelt's famous speech, "The Man in the Arena." This speech includes the line, quote, "It is not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done better. The credit belongs to the man who is actually in the arena." You get the picture. Wow, I felt as if a legend in cardiology was scolding me personally. I mean, I am certain that my K index is very high, given the fact that I am primarily a doctor and I'm active on social media. But I wasn't the only one moved by Dr. Califf's editorial. Darren Daly, a statistician, Dr. Venk Murthy, an academic researcher from Michigan, Vinay Prasad, an oncologist, Brian Vardabedin, a pediatric GI specialist, and Ryan Daly, a thoughtful private practice cardiologist in Indiana. All of these people sharply opposed Dr. Califf's take of the new democracy of ideas in the digital space. I think you all should read Steve Stiles' amazing news coverage of this. It's a really good piece, and thankfully it's more than 800 words. In other words, it's a nuanced piece. So let me conclude this topic with 4 major points. First, Dr. Califf is one of the most impressive figures I have seen in medicine. He deserves the utmost respect for his contribution to societal good. I doubt he would ever listen to a podcast from me, but if he did, I would say thank you, Dr. Califf, for all that you've done for society and cardiology. But these accomplishments do not mean we cannot respectfully oppose his take on social media. So my second point, critical appraisal of trials by the consumers of the evidence, clinicians and patients alike, must be robust. And this critique is never personal. When a person like John Unides from Stanford or someone like him points out the problems with small effect sizes or biased trial designs or spin in the language of manuscripts, this is not a knock on the researchers. This is important critical appraisal. It's vital for the translation of evidence to patients. Third point, social media offers another way to conduct peer review. While the wisdom of the crowds is far from perfect, neither is the secretive insular peer review that is ongoing now. Remember what the legendary Drummond Rennie said about peer review. He said that if it were a drug, it would never be approved. Well, on social media, the critiques of a trial can be critiqued in real time and in open, transparent form. Fourth point, I really love the statistician Darren Daly's citation of Popper in his blog post about this topic. Popper said, "The secret of intellectual excellence is the spirit of criticism." Now, I've co-authored a paper with Dr. Kahn and others on this thing called the fragility index. I really liked the paper because it brought attention to the smallness of effect sizes in many clinical trials. But the fragility index paper was skewered by people online, some of them my friends. And in being skewered, I learned a lot, and I never thought it was personal. Social media has its downsides, but its embrace of criticism and meritocracy of ideas makes it a net positive in my view. Next topic is hopeful news from CMS. For my international listeners, CMS is the Center for Medicare and Medicaid Services, which is the largest payer, a government payer, in the United States. In this conference, CMS Director Seema Verma said that the agency's new plans aim to reduce physician fatigue and frustration. And no doubt, nonsensical quality measures are a core reason for our frustration. That current quality measures likely reduce quality and increase patient harm is A, known by every clinician who sees patients here, and B, a source of moral distress. Verma emphasized that in CMS's Patients Over Paperwork initiative, E&M code, evaluation and management codes, have been reformed to simplify documentation. She says this move will save the country billions of dollars and save docs millions of hours of burden. Some clinicians have pushed back on the reforms of E&M coding because it will reduce salaries. Now, I cannot say I'm an expert on the economic aspects of this, but I am 100% in favor of simplifying the current coding system, which is awful. Now, another area of change Verma's talked about was improving the merit-based incentive payment system. This too is complex and confusing. Verma says future quality measures will be more specialty specific. The details here are pending, but something has to be done about fixing the checkbox notion of quality. I mean, can you imagine grading primary care clinicians on how many patients they send for screening tests, most of which have no proven mortality benefit? And recently, speaking of quality measures, I was involved with a case of a frail, elderly patient who could barely eat or walk, whose doctors insisted she be put on high-dose statins because of fear of falling out of quality measures. Finally, no quality measure could be more farcical than the meaningful use measures of how much one used a terrible EHR system. So here is hoping that CMS's Meaningful Measures 2.0 will actually allow clinicians to report quality measures without lifting a finger. Now, maybe I am naive, but it seems to me that it would be easy to measure how a clinician's patients are doing with an electronic health record system. We were recently told in an administration meeting that increasing numbers of patients that we see will be in payment systems in which cost and outcomes will be counted. Imagine that. In other words, rewards will go to caregivers who can keep their patients healthy while using fewer health resources. This news made me tingle with delight because finally, the medical conservative will be rewarded rather than penalized. I'm no policy wonk, and I may be wrong about this, but I think Seema Verma is on the right track. Third topic today, a new cholesterol drug. This week, FDA approved the inhibitor of ATP citrate lyase, bempedoic acid, for adults with heterozygous familial hypercholesterolemia or established heart disease who require additional LDL lowering. The oral drug works by suppressing cholesterol synthesis and by upgrading LDL receptors. In March, the New England Journal of Medicine published the Clear Harmony trial, an RCT of patients with heart disease or heterozygous FH who had an LDL of at least 70 while taking maximally dosed statins. The primary endpoint of this trial was not outcomes, but safety. Secondary outcomes was percent change in LDL cholesterol. Now, the incidence of adverse effects were about 78% in both the bempedoic acid and control group. And I know that sounds high, but they counted everything. Serious adverse events were seen in 14% of both groups during the intervention period, but the incidence of adverse events leading to discontinuation of the regimen was higher in the bempedoic acid group than in the placebo group. It was like 11% versus 7%. The incidence of gout was also higher in the bempedoic acid group, 1.2% versus 0.3%. And another not so great adverse effect, the risk of tendon rupture, was 0.5% with bempedoic acid and 0% with placebo. Now, tendon ruptures involved all different kinds of tendons, rotator cuff, biceps, Achilles, and it occurred within weeks to months of starting the drug. At week 12, 3 months, bempedoic acid reduced the mean LDL cholesterol by 19.2 milligrams per deciliter. This was about a 16.5% change from baseline. Now, the likely mechanism for increased gout is competition between a bempedoic acid metabolite and uric acid for the same renal transporters that are involved in the excretion of these compounds. The magnitude of the LDL reduction is similar to reductions from ezetimibe added to statins. Notably, there were no significant differences in major adverse outcomes in this trial, though it was not powered for that outcome. In the same issue of the New England Journal at that time, in March, Dr. Brian Ferentz and his colleagues presented a Mendelian randomization study looking at ATP citrate lyase and future heart disease. Now recall that Mendelian studies are like nature's RCT. In these, patients with genetic inhibition of ATP citrate lyase were followed for cardiac events. Ferentz and colleagues first constructed a genetic score which was composed of inherited genes that encode the ATP citrate lyase and also the statin gene, the HMG-CoA reductase, and this creates instruments that mimic the effect of bempedoic acid and statins. They then compare the association of these genetic scores with lipid levels and the risk of cardiac outcomes. And what they found was that patients with the ACLY and HMG-CR gene profiles looked similar. Genetic variants that mimic the effect of ATP citrate lyase inhibitors and statins both appeared to lower LDL cholesterol levels by the same mechanism of action, and they were both associated with similar effects on the risk of cardiovascular disease per unit decrease in the LDL. Neither lifelong genetic inhibition of ATP citrate lyase or lifelong genetic inhibition of HMG-CoA reductase was associated with an increased risk of cancer. My comments on this is that I understand the reason for the approval, but I can't see much use of this drug without an outcomes trial, which is ongoing. Recall that an LDL level is a mere risk factor for disease. It's a surrogate. Having a high LDL level is not the same as having a disease. Statins have been so important not because they reduce LDL, but because they reduce cardiac events. What moves the needle in the care of patients with heart disease is not a drug that changes a level of a chemical in the body, but a drug that reduces the chance of having a cardiac event or reduces the chance of dying. We shall see if bempedoic acid accomplishes that. And no matter what the drug rep tells you over free burritos, the higher risk of gout and tendon rupture will not be small things. Tendon ruptures and gout only seem small when they happen to someone other than you. Fourth topic is carotid interventions. Journalist Mitchell Zoller has a nice recap of an important abstract presented at the International Stroke Conference in LA. This abstract, this study, combined data from 2 RCTs of carotid stenting versus carotid endarterectomy. The 2 trials were CREST and ACT1, and the study asked the question, how does carotid stenting compare to carotid endarterectomy in older patients without symptoms? This is a newsworthy study because with the advent of imaging tests, there are lots of older people blissfully living with significant disease in their carotids without symptoms. The combined study included about 2,500 patients. The primary outcome was a combined incidence of periprocedural stroke, MI or death, plus ipsilateral stroke during the 4 years of follow-up. Among patients who underwent carotid artery stenting, the outcome occurred in roughly 9% of patients aged 75 to 79, and in about only 3% in those younger than 65 years. That's a hazard ratio of almost 3, which was statistically significant. However, patients who underwent carotid endarterectomy showed no similar relationship between age and outcome. Here, the incidence of the primary outcome among the carotid endarterectomy patients was roughly the same, about 3.5%, regardless of age. The authors did a second analysis that considered age as a continuous variable, and they showed a sharply spiked increase in the risk for the carotid artery stent patients compared with carotid endarterectomy once patients reached about age 73 to 75. Now, while these results were similar to the results of a meta-analysis of pooled data from 4 RCTs, this published in The Lancet, that meta-analysis found that carotid endarterectomy was clearly superior to carotid artery stenting in patients aged 70 to 74. The researchers rightfully noted that this was a post hoc analysis of 2 different trials and the total number of events was low. But the biggest point to be raised here, and the reason it closes the podcast, is that neither carotid artery stenting nor carotid endarterectomy may be the best treatment for patients with carotid disease who have no symptoms. And kudos to Mitchell Zoller for emphasizing this in his news story. Recall that the evidence for doing any carotid intervention stems from very weak data from very old trials before the era of high-potency statins. I've given talks on the pitfalls of vascular screening, and in those talks, I show studies looking at outcomes by country. Why? Because the rate of carotid endarterectomy for asymptomatic disease in places like Denmark and Canada are very low, almost zero, while the rate of carotid endarterectomy for asymptomatic disease in the U.S. is very high. The vast majority of carotid endarterectomy here is for asymptomatic disease, yet cardiac outcomes in Denmark and Canada and the U.S. are no different. Thankfully, the CREST-2 trial is comparing carotid endarterectomy and carotid artery stenting with optimal medical management in the current era. It's scheduled to report results next year, and I'll bet you multiple espressos that this trial shows that similar to coronary interventions in stable disease, carotid interventions will add no benefit over optimal medical therapy. So that's it for this week in cardiology. As always, I am grateful that you listened. Thank you. And remember, please, if you like this podcast, tell a friend, go on to your app, give us a rating or a review, and it helps others find us. Until next week, this is John Mandrola from the Heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org on Medscape.